Good morning. It's an honor and pleasure to be with you this morning. I was asked to talk a little bit about, from an insurer's perspective, what it means to start to explore coverage with evidence development. So for some of you, might be a familiar term. For others of you, that might be a new term. So I'll spend a few minutes unpacking that term. Are you all familiar with that term? I should just clarify. Is that a familiar term in this audience? Is this a shy audience? I don't know how we're going to play this out. So I'm originally from. You said you're originally from South Carolina. I'm a kid originally from Oklahoma, just so you know. So that means that we interact. If you're quiet, we don't know what that means. So you got to like work with me a little bit, okay? And I grew up in that portion of the Bible Belt where it's Pentecostal preaching, and so it's kind of, even though you're the minister, it's audience participation in the congregation. That's kind of how it flows in Oklahoma. So feel free to work with me a little bit, okay? It's fine. Let me back up though, because some of you may or may not be familiar with that term of art, coverage with evidence development. I am the Chief Medical Officer for Blue Cross and Blue Shield Association. Blue Cross and Blue Shield pretty much has 1 in 3 Americans walking around with that Blue Cross or Blue Shield card in their pocket or their purse or wallet, as you may. And so it's an honor and a pleasure to serve in that role, primarily responsible for looking over opportunities where we can improve the health and the life of the members that we are honored to be able to serve. In a prior capacity, I had a similar opportunity as the Deputy Chief Medical Officer for Medicare and Medicaid at the Centers for Medicare and Medicaid Services. When I first got introduced to coverage with evidence development was at that CMS, in that CMS environment. And the construct of the idea is there's opportunities that we're seeing unfold where the evidence is starting to show something positive in the way of new evidence is being developed, but might not yet meet your evidentiary standard that you would normally have as you evaluate the literature. And so you end up making a determination at CMS, well, is this an opportunity where we might do interim coverage while we continue to let the study unfold to be able to determine it will actually eventually improve lives and healthy outcomes? Why would you necessarily do that? You might do that because you would particularly have concerns that if you wait till the study ended up proving the positive results that you anticipate with the early intervention, you may have been putting lives at risk that entire time. Okay, that's traditionally how we've looked at it. So it's not a role that we traditionally look at in terms of any new innovation that's coming down the pipeline. You want to put them into coverage with evidence, but it's primarily for those situations, those unique situations where you have specific concerns that preliminary information is indicating that the status quo is putting people at more jeopardy than if you actually were to cover those individuals under study protocol. Okay. Now, given that baseline, and we'll get into that a little bit, I think, when we get into the discussions with the panel. Let me back up a little bit, because when I was asked to talk, of course, I don't have any slides, so you don't have to worry about anything of that nature. Again, I grew up in a Pentecostal world, so like preachers could really recite Jesus wept and go 2 hours, right? So it's pretty, when I saw 30 minutes, I said, okay, this is much more about us engaging with each other and having some fellowship than necessarily running through a bunch of slides. To make it simple, I was trying to think of which way I should approach the audience. So one analogy is to be able to talk about the complexities of coverage with evidence development, because it really is a complex issue, because you have a lot of balances and trade-offs. And so I was thinking the easy, simple example to a layperson might be trying to create healthy French fries that taste great, right? McDonald's still has a lot of people saying, I wish they would just go back to the regular French fries and let me deal with my own health, right? Because there's a balance and there's a trade-off that you're really trying to accomplish. But I ended up saying I think the more appropriate analogy is probably from the educational realm, where you hear the term flipped classrooms. Are you guys familiar, being exposed to that particular construct or that particular term, flipped classrooms? And so this is starting to unfold more and more across the country where people are taking advantage of this. So most of us probably were in an era where they had what they would consider to be a traditional classroom. Those traditional classrooms, by and large, came out of an era in which we were having the Industrial Revolution. And so what you were normally doing is taking that same approach that you were doing on the factory floor and applying it to the classroom. Most people call this Taylorism, where it originally originated, but it's really taking things that were occurring on the factory floor where you had a factory manager that pretty much knew what the specifications were that they were trying to achieve on the factory floor, and then you start to bring that into education. When you brought it into education, that meant that the teacher was primarily the person that had all the knowledge, was a central focus for the conversation that was going to occur in that classroom, and their job, by and large, was to disseminate information and make certain those students knew the tasks that they were required to be able to address, which we called homework, and then they had to bring those tasks back and be able to demonstrate that they could actually achieve that particular task, and we call that education. That's the traditional model by and large, and I'm simplifying in the interest of time. Flipped classroom comes along and says, well, you know, we're beyond that industrial revolution era, and we actually find that it's quite limiting and it doesn't serve most people pretty well, because by and large what you were doing is doing a generalized approach to education and wasn't specific to the individuals in the classroom. And so the flipped model ends up saying what we want to be able to do is have a blended learning experience, so that when you come into the classroom, it's not necessarily didactic where the teacher is necessarily the person of central focus and that they're disseminating all the information, but instead it is an interactive session. It's a blended learning session. And so fundamentally the educational approach changes on its head, which is why they call it a flipped classroom. The reason why I thought that analogy is probably more appropriate is because we're seeing that unfold in somewhat when we talk about the activity that people will talk about from a patient's perspective or consumer's perspective, coming into healthcare and being more recognized as the person that's probably most central to understanding what type of evidence is required to make a difference for healthy outcomes. Okay. Fundamentally flips it from when I was coming through my training, where similar to that teacher, the clinician was the primary essential focus, had all the knowledge base related to any particular condition, and that was the knowledge base that we primarily utilized to be able to make determinations from an evidential standpoint, right? Suddenly now we're starting to see consumer scientists, where consumers are pretty much trying to be on a par footing, if not a higher footing than those clinicians, and primarily because those consumers / patients are the ones living with that particular condition. And so because they're the ones living with that particular condition, they may eventually have more knowledge than even the clinicians that's supposed to be the expert in terms of treating that particular condition, right? We also know that with the age of what's happening in this information age, that is readily available, where in the past the clinician might be the only source of that particular information. Now information is flowing much easier. The cost of acquiring that information is much lower for the average consumer. And so it's decreasing the disparity between that clinician and the average consumer because of that difference in accessibility of information that previously didn't necessarily exist. If you add to the fact that now we're in a world where people are often talking about precision medicine, which means personalized healthcare, it is also a game changer. So similar to when I gave that analogy about the blended learning experience in the classroom setting, where you're not necessarily disseminating generalized information, but you're trying to make certain that those individual students get what they need to be able to improve their education. Personalized healthcare is along that same trajectory, as saying that we're trying to get to the point, if possible, it's a big task, but if possible, we can get to the point where we're starting to personalize healthcare delivery so that each individual could be optimize their healthcare for their particular self or their particular family versus doing a generalized approach. The problem is that's where the balance gets in. That's where it gets pretty tricky, because traditionally what we look at is study designs that have to be large enough to be able to demonstrate the effect size that we need to be able to see. And so that normally doesn't allow you to do what most people call a N of 1, meaning you only have one person in your sample. You can't extrapolate that. That is the rub that we're traditionally looking at when we talk about trying to understand the evidence and how we're going to move it forward. So I say that to give you a context for the panel discussion, that for us it's much more than necessarily having an advocate or a consumer or patient representative at advisory panel. It's more about trying to understand what's the fundamental changes that's going to occur over the next decade, and how do you start to incorporate similar to a flipped classroom where you can make certain that you're doing your best for these fundamental changes in roles that we believe is going to occur, because everybody's talking about consumer-directed healthcare. And I've yet to find any particular payer or insurer that's pushing back on consumer-directed healthcare at all. I think everyone agrees that that's the right approach to be able to go, and the question is trying to be able to cross the chasm to figure out how to get there. Those are the conversations that we're having unfold. So to keep on task with the discussion, now that I give you a context and a sense of what the dilemmas are, the trade-offs that are really unfolding a little bit as we're trying to move forward to 2020 and beyond, let me specifically come back now and talk a little bit about the coverage with evidence, since I was asked to specifically speak to that point in the context of that broader discussion. For coverage with evidence development, it's important to understand that there's also trade-offs in that particular arena, if you will. Traditionally, insurers and payers don't pay for research. Research is in a separate category, separate traditionally from what you would have under the contract of an insurance. So I mentioned at the start of my discussion that I used to work for Medicare, and the way that the Medicare program works is fundamentally different by and large than how a commercial insurer works, because by and large on the commercial insurer side, it is literally governed by the contracts by which those unfold. Okay, whether you individually purchase a particular insurance product or insurance plan, it is governed by the benefits within that particular contract. And similarly, whether you're an employer and you're getting your health insurance through an employer, is similarly dictated by those particular benefit design of that particular contract. Most of those contracts require a standard by which the evidence is being able to review to be able to determine whether it is medically necessary. If it's not medically necessary, most contracts won't necessarily cover that particular construct. It's the reason why you might separately have research dollars through foundations or other activities, but you wouldn't necessarily get it through your traditional insurance benefit. Coverage with evidence development, similar to what I said at CMS, is trying to find a way in those unique situations where I think it's vitally important or critical to be able to see, and a lot of times you're trying to see if you can actually pull this off, where patient safety is normally what I'm looking for, is whether or not there are some patient safety concerns related to the status quo, meaning the way that we're currently delivering services or delivering treatment, that would suggest to me that if we don't take advantage of some early signs of positive studies, that over the course of that study period, we might be unnecessarily subjecting individuals to more harm than they otherwise would have need to undergo while we prove that the study is meeting our objectives from an evidence standpoint. So when we talk about the value of coverage with evidence development, it is a value in the sense of trying to be able to manage that trade-off between the evidence that's required to be able to prove the effect that you need to be able to prove this, so show that, okay, this has proven to be medically necessary, and the exposure to the individuals that are going through that study process, and the other cohort that's continuing to go through the traditional delivery of the service model that's not within the individual confines of that study. That is the balance that you're trying to seek. Depending upon how long the study takes, it's also a balance, because depending upon what it is, you're also trying to figure out how long is that going to take before it necessarily proves the value proposition that it's really medically necessary. Is that something that has a short time horizon, or is that something that's really going to take 3-5 years out? And that makes it pretty difficult the longer the time horizon is for you to be able to demonstrate the medically necessary for a particular study. I will transition. Where am I on time? Am I okay on time? Okay. Let me transition to another component, because I think in this environment, and we're a rather small gathering here, I do want to reserve plenty of time for the Q&A, because I think you'll learn more than me talking. I mean, I don't mind you looking at this bow tie. I think it's nice, you know. So as much shine, you know, we can put as much spotlight you want on it. I think, you know, the store would be happy if you did that. But I'd much rather engage with you. Let me switch, because you guys have specifically used the term value, at least in describing this conversation. I want to talk a little bit about that unique term. Excuse me. So from a quality measurement standpoint, there's a lot of ways that people have talked about value, and oftentimes what they're talking about is the marginal value. So they're oftentimes in healthcare services or healthcare economics, it's talking about the value, meaning what's the quality relative to the cost. That's what you hear most people talking about. So you're really talking about the marginal value. What's the additional unit of quality I get relative to the cost? Some will go on and do that even more aggressively, and where they do a cost-benefit analysis or they do some other type of utility analysis, cost-effective analysis. They're ultimately trying to be able to look at that construct. The portion that we're trying to explore in more detail, and I think Q and some others can help with, is what's the value from the standpoint of those individual patients that are living with that condition, which is why you're starting to hear more and more people talk about patient-reported outcomes and how can we do a better job of incorporating patient-reported outcomes. Traditionally, that has not necessarily been highly weighted. There's starting to be more and more where the approaches to being able to do patient-reported outcomes, to be able to incorporate that into the way in which we're looking at whether it's medically necessary or not. There's a lot more research is required to be able to incorporate those patient-reported outcomes so that that can be standardized over time so that everyone that's doing evidence reviews feel pretty comfortable about the way in which we are approaching patient-reported outcomes. So that is an area that I think is ripe for more research, more discussion, more approaches to be able to standardize that across the board. Lastly, I mentioned, since I know after the break there's a panel that's going to be coming up after the break, I believe it's after the break, on variability or disparities or health inequity. So let me just preface some discussions around that. As we look at what's happening, we definitely believe that there's this adage that I think most of you are familiar with that says the future is here, but it's just not evenly distributed. And so we're constantly trying to look through the data to be able to understand what that means, particularly because Blue Cross and Blue Shield, unlike some others, is pretty much in every zip code. And I say pretty much because there's some zip codes where there are no people. Oklahoma happens to be one of those places where you might have more cattle than people in a zip code, right? So that's why I say pretty much in every zip code. But the idea is because we're in every zip code where people are, we have data at that particular level. And so it allows us to be able to start to understand the variability that we're seeing in terms of treatment designs, study designs in those particular constructs. And we definitely want to be able to find ways in which we can reduce that type of variability. And so we're looking for opportunities to be able to continue to do that. Later this year, I mentioned precision medicine. We're hoping through some partners to be able to come out with information that's showing just with genetic testing and how the genetic test is unfolded, that there's variability across the country, how that's unfolding. Just yesterday, we released a report, a Health of America report on opioids and what we're seeing with the opioid epidemic. And it's clearly variability in terms of opioid epidemic across the country, not only in terms of prescribing patterns, but in terms of the rate at which people are being exposed to those opioids, and subsequently what that means in terms of opioid use disorder. No question about it. In fact, to the point when we look at some areas around the country, the opioid use disorder pretty much follows what you would think from a communicable disease standpoint. It follows commercial routes and other ways that you would think like traditional communicable disease would follow. And so it allows us to start to understand a little bit more about how those social practices are unfolding at a local level and how that ends up leading to the variability or the inequities that we see or disparities around the country and what we might need to be able to do from an infrastructure standpoint. The reason why I highlight that as a particular example is part of what we're starting to look through are ways in which we can work with consumer groups to be able to understand what data they already are utilizing as they share data with each other, and what data we might be able to support or structure in a way that really is feasible and has an impact, because everybody say they want data, but then if they're not really able to effectively utilize it, then we won't necessarily get the outcomes that we are intended to be able to get, and it'll be at a cost that's prohibitive. And so we're starting to explore ways in which we can work with consumer groups to be able to understand how they utilizing data with each other Some of them have data registries. How might we be able to assess those particular data registries? And in exchange, what do they need from us to be able to keep moving forward and build out their data registry so that it can have the impact that you're expecting it to be able to have for all you that might be living with that condition or might have loved ones living with their conditions, and you want to be able to see them move forward. So with that, I'll pause and turn it over and join the panel if that's okay. So thank you for allowing me to provide a few opening remarks.